Want to check if you can hear me well. All right, great. And can you see the PowerPoint presentation and the blackboard? I'm doing well, thank you for asking. All right, great. Any questions concerning the previous discussion from last class? A quick overview of what we've discussed last time, if you remember. We did study the breathing mechanics. And if you remember, we did have multiple pressures that will be affecting the inspiration and expiration, allowing you to either allow the air to flow to the inside or to the outside of your lungs. If you remember, your lungs are located in your chest, and the chest has a membrane that is formed of two layers. One layer was covering the lungs from outside, and the other layer was lining the chest cavity from inside. This is what we've called the pleura. And if you remember, the different pressures that we were dealing with last class that affected the air movement from one side to the other. First pressure that we discussed was my atmospheric pressure. And remember, the atmospheric pressure is equal to 760 millimeter mercury, but we consider this as our zero pressure because anything is going to be compared to this pressure. So this is our like the zero score for the respiratory pressures. Inside your lungs, we've got the intra-alveolar pressure or the intrapulmonary pressure. And as you see on here, the lungs are going to be directly connected to the atmosphere. And if I am directly connected to the atmosphere, this tells me that the air can flow in and out of my lungs. And remember, air, like anything else, gonna be flowing from the side with high pressure to the side with lower pressure until you equalize the pressure on both sides. So almost always the pressure within my lungs is going to be equal to the atmospheric pressure. It's going to be a 0 millimeter mercury because it has the same pressure as the atmosphere. So compared to the atmospheric pressure, it's going to be a zero pressure. I am almost always equal to the atmospheric pressure. On the other hand, the pressure between the two layers of the pleura, which is occupying your chest, it's my intrapleural pressure. And if you remember, this intrapleural pressure is always going to be negative. Why is it always going to be negative? Because your lungs tend to collapse all the time. Your chest wall tends to expand all the time. So you're moving the two layers away from one another, creating a vacuum. And what is by definition a vacuum? A vacuum is simply a pressure lower than the atmospheric pressure. So this means I'm creating a negative pressure. So if I am creating a pressure of 756 millimeter mercury compared to the atmospheric pressure, considering that the atmospheric pressure is my zero pressure, so this is going to be a negative 4 millimeter mercury. So it's almost always a negative, it's always a negative pressure. If this negative pressure was disrupted, remember a person got stabbed in the chest by a knife, for example. Breaking the parietal layer of the pleura. This will allow the air to flow from the atmosphere between the two layers of the pleura. So this means that this pressure gonna drop to, or gonna increase to 0. Remember, what keeps your lungs inflated? It's a pressure that we've called the transpulmonary pressure. How my lungs are kept inflated. How do you inflate a balloon? Either you pump air from inside, so inside pressure is greater than the outside pressure, so the net effective pressure is going to be a positive pressure, which will keep my lungs inflated. Or if I don't have something to pump the air in my lungs, I don't have an inside pressure. Inside pressure is a zero pressure. It's equal to the atmosphere. So I'm not pumping anything in my lungs. The effective pressure in this case is going to be the suction pressure that is from outside. So if I'm starting here a pressure of 0 on the inside of my lungs, minus the suction force from outside, which is the my pleural pressure. So 0 minus negative 4 is going to be equal to 4 millimeter mercury. This is the effective pressure that keeps my lungs inflated. So my lungs are inflated by a pressure of 4 millimeter mercury, which is simply the difference between the pressure inside and the pressure outside. Inside is a 0 pressure. I'm not pushing air inside, so the pressure inside is a 0. But outside of the lungs, I have a negative pressure, suction force on the outside. So this suction force is what keeps my lungs inflated. So back to our example on here, if a person got stabbed by a knife in his chest, breaking the parietal layer of the pleura, allowing the air to flow in between the two layers of the pleura, what's going to happen is this pressure drops to 0. So rather than having 0 minus negative 4, I have now 0 minus 0, which is going to be equal to 0. So the effective pressure, the net force that keeps your lungs inflated, is going to be a 0 pressure. Putting this into consideration, so what's going to happen to your lungs in this case if a person got stabbed by a knife in his chest and you remove the knife, breaking the seal, the lungs will collapse. Because what keeps the lungs inflated is not air that you pump in. Air doesn't get pumped in. But the suction force that you are creating from outside, it's what keeps your lungs inflated. All right, so looking back, what happens during inspiration? During inspiration, the inside of my lungs is a 0 pressure. It's equal to the atmosphere. The intrapleural pressure, the pressure between the two layers of the pleura, is -4. So the transpulmonary pressure before I start the inspiration is 0 minus -4, which is equal to 4. So the pressure that keeps my lungs inflated is a 4 millimeter mercury. What happens during inspiration? Remember, inspiration is an active process. So you need muscle to contract in order to allow inspiration to take place. So the most prominent muscle during inspiration that you're going to need to contract in order for you to allow air in is going to be the diaphragm. So the diaphragm, when contracted, this will do what to your chest? The chest volume gonna be increasing. Also, when you contract the intercostal muscles, this will cause the elevation of your ribs. I'm expanding the volume of my chest. And if you remember, what's the relationship between volume and pressure? If you increase the chest volume, either by contracting the diaphragm or you did elevate your ribs, you are increasing the chest volume, and so the chest pressure should be decreased. And what is the pressure in the chest? Simply is the intrapleural pressure. This is the pressure occupying my chest. So intrapleural pressure, rather than being -4 during inspiration, what's going to happen to this pressure? This will drop to -5. Remember, -5 is lower than -4. So now the transpulmonary pressure, the pressure that keeps my lungs inflated, is 0 minus -5. It's going to be 5 millimeter mercury. So the net force, the net pressure that keeps my lungs inflated in this case is going to be increased during inspiration. I will increase the pressure that keeps the lungs inflated. This, in other words, what am I doing to my lungs? My lungs will be expanding. And as I increase the volume of the lungs, what's going to happen to the pressure on the inside of the lungs? I have a drop in the pressure. So what was the pressure inside your lungs before you contract the diaphragm, before inspiration? It was a 0 pressure. It was equal to the atmospheric pressure. So this 0 pressure will drop to -1 millimeter mercury. It will drop 1 millimeter mercury below the atmospheric pressure. So now outside of my lungs, in the atmosphere, I have a 0 pressure. Inside my lungs, I have a negative pressure, which is -1 millimeter mercury. So considering the difference between the two pressures, atmospheric pressure is a 0 pressure, intrapulmonary pressure or intraalveolar pressure is going to be a negative pressure. So air will flow from high pressure, which is outside, to the low pressure, which is inside my lungs, allowing inspiration to take place. Until when you're going to be breathing air in? Until you equalize the pressure. So at the end of inspiration, the pressure in the lungs returns back to a 0 pressure. What happens during expiration? So expiration is a passive process. So let's look at how the pressures look like at the end of inspiration. At the end of inspiration again, my intrapulmonary pressure is 0. My intrapleural pressure is the pressure between the two layers of the pleura. Rather than being -4, it was -5 because my diaphragm is contracted. So intrapleural pressure is -5, so the transpulmonary pressure still gonna be a 5 millimeter mercury. This is what keeps my lungs inflated. This is a transpulmonary pressure at the end of inspiration. Intrapleural pressure is -5. Transpulmonary pressure, the effective pressure that keeps my lungs inflated, is 5 millimeter mercury. All this is what happened during inspiration. You see on here, intrapulmonary pressure is going to be increased to 0 due to the airflow, but the intrapleural pressure going to remain -5. So the transpulmonary pressure is still going to be 5 millimeter mercury. So looking at this here, this is the picture at the end of inspiration. So during expiration, what you're going to need to do, you need just to relax your respiratory muscles. So when you relax your diaphragm, the diaphragm is going to be moving up. When you relax the intercostal muscles, your ribs going to move down. So what happens to my chest volume? Chest volume during expiration is going to be decreasing. And if I decrease the volume of the chest, what happens to its pressure? The chest pressure going to be increased. And what is the pressure again in your chest? It's the intrapleural pressure, the pressure between the two layers of the pleura. So intrapleural pressure, rather than being -5, it's going to increase to become now -4. So during expiration, what happens? The chest volume decreases, its pressure goes up to -4. So now the effective pressure that keeps my lungs inflated is going to be 4 millimeter mercury instead of, at the end of inspiration, it was 5. So the effective pressure that keeps the lungs expanded has been reduced. So I did drop this pressure that keeps my lungs inflated. So the lungs will be recoiling because I did reduce the force that keeps it expanded from 5 millimeter mercury. I drop it to 4 millimeter mercury. So what's going to happen when you reduce the volume of the lungs? When you reduce the volume, remember, you increase the pressure. And when you increase the pressure, the pressure in the lungs, rather than being a 0 pressure, it goes up to 1 millimeter mercury. Remember, outside of the lungs, you're still going to have the same atmospheric pressure, which is my 0 millimeter mercury. So inside of the lungs, during expiration, I have a pressure of 1 millimeter mercury. Outside of the lungs, I have an atmospheric pressure, which is always going to be a 0 millimeter mercury. So what happens? air will flow from high pressure to low pressure, from inside of the lungs to outside of the lungs. This is what we call the expiration. All right. Any questions concerning how expiration and inspiration take place? All right, great. So we're looking today at the physical factors that will be affecting the pulmonary ventilation. How this pulmonary ventilation that we've been discussing gonna be affected, and what are the factors here that will play a role in determining the amount of air and the force of contraction that you are required to perform in order to allow air in and out. All right, so three factors. First one is going to be your airway resistance. If you remember, when we discussed the relationship between pressure and resistance, when did we discuss the relationship between pressure and resistance? In the vessels, right? Exactly, Martin. In the mean arterial pressure, if you remember, mean arterial pressure was equal to the flow, which is the cardiac output, times the total peripheral resistance. So what will determine the pressure? Two things, flow and resistance. So if I am getting air into my lungs, in order for me to allow this air to travel, it needs to overcome the resistance applied by those airways that I'm passing through. So I need to have a force greater than the resistance created by the friction between the air and my airways. What if the force by which you are getting the air, the pressure of the air, is lower than the resistance applied by those airways? What's going to happen? The air will stop flowing. So resistance here can be playing a major role in affecting your ventilation, whether it will determine whether you would be able to get air from outside or not. This is the first factor that we are discussing today. The other factor is my alveolar surface tension. If you remember, the air sacs were formed by alveoli. They were lined with a thin film of water, which will allow the gases to travel. Remember, you can't allow gas bubbles to travel to your blood. So the gases that you are absorbing gonna need to be in a soluble form for them to be able to travel to your blood. So this, putting this into consideration and knowing the characteristic of the water particles, if you remember, I have an attractional force between the hydrogen and the oxygen, especially when the water is in direct exposure to the air. It creates a surface tension, which gonna be causing the lungs to collapse. So this is another factor that's gonna be affecting my ability to get air from outside in. Remember, I did have attractional force between the water molecules because of the more positively charged side, which is the hydrogen part, and the more negatively charged side, which is the oxygen part. So this creates hydrogen bonds between the water molecules. So this surface tension of the fluid located inside of my lungs is going to be playing a major role in determining whether I will be able to ventilate my lungs or not. Another factor that we're going to be looking at is how good is your lung expanding and recoiling back to its normal size. How good is the elasticity of my lungs? Am I able to expand the lung or it's too stiff? Am I able to recoil the lung or it lost its elasticity? All right, so we call this is my lung compliance. Lung compliance. So 3 factors that we're looking at today that will affect the ventilation. Those are my airway resistance, my alveolar surface tension, and the lungs compliance. First, starting with airway resistance. Remember how many alveoli did we have in the lung? You remember? 300 million, exactly. 300 million alveoli. Millions and millions of alveoli, and those going to require millions and millions of terminal bronchioles. If you remember, how many orders of division do we have? We have 23 orders of division in order to reach the terminal bronchioles. So the trachea going to be dividing 23 times. Remember, the trachea splits into 2 main bronchi. Each main bronchus splits into lobar bronchi. Each lobar bronchus is going to split into segmental bronchi, and so on. We have 23 orders of division. All right, so this tells you what about the terminal bronchioles? That they have a very, very, very small diameter. And having this very small diameter of the terminal bronchioles, what do you think is going to be its effect in terms of resistance? Do you remember, if I have large diameter, would I have higher or lower resistance compared to if I have a smaller diameter? If you have a large diameter, flow is going to face very, very low resistance compared to if you have a very small diameter, squeezing stuff through the small diameter. So if I have a small diameter, this tells me I have high resistance, right? And if I have a large diameter, I have a very low resistance. Putting into consideration here the diameter of those terminal bronchioles, what do you expect to see in terms of resistance of the airways? High resistance or low resistance? I'm traveling from the trachea to reach my terminal bronchioles. So traveling here from a large diameter into this small diameter. would I be facing a high resistance or a low resistance? High resistance, higher resistance. So is it difficult for you to breathe right now? You're sitting in your chair. Do you need to exert effort to breathe, to overcome this resistance? So we did agree that small diameter creates high resistance. So I'm expecting to see that those terminal bronchioles will definitely going to be applying a much greater resistance. But why I don't feel that there is any resistance for the air to flow into my lungs? There is so many of them, exactly. So you have millions and millions of those terminal bronchioles. So which one has a greater diameter, your terminal bronchioles or your trachea? What do you think? Which one will have a larger diameter? Definitely your terminal bronchioles. Why your terminal bronchioles will have a larger diameter? Why your terminal bronchioles have a larger diameter? Because you have millions of them. So if you are passing from one trachea into one terminal bronchiole, yes, at this point, you're gonna have a huge resistance. Nobody will be able to overcome it to allow the air to flow. But here I have millions of terminal bronchioles, and those millions of terminal bronchioles, they have a large diameter. They have a large total cross-sectional area. So having more of the terminal bronchioles will result in a large cross-sectional area. I have a larger diameter in my terminal bronchioles because I'm not passing from one trachea to one terminal bronchiole. I'm passing from one trachea to millions of terminal bronchioles. The vacuum effect is outside of the lungs. This is what drives the air. So this is something that we've mentioned earlier. So the vacuum here is outside of the lung. We're not discussing the vacuum on the outside that pulls the lung. We are discussing why the air that flows here gonna be able to flow, although the effective pressure that pulls it, is what? The difference between atmospheric and pulmonary pressure, right? So during inspiration, when you contract your diaphragm, your lungs will have a -1 millimeter mercury, and outside you have a 0 millimeter mercury. So the difference in pressure is going to be 1 millimeter mercury. Is this going to be enough for me to pull the air, and this air to be able to overcome my airway resistance? Do I have a significant airway resistance that I need to overcome? Actually, you don't have any significant airway resistance normally. You don't have any significant airway resistance normally. Why? Because simply you are traveling from a large diameter, which is the trachea, to a small diameter, yes, which is a terminal bronchiole, but you're gonna have millions of them. So this will not be applying much resistance against the airflow. So when would I have a problem with the resistance of my airways if a person, for example, has asthma. So during asthma attack, what happens? If I have asthma, I have hypersensitivity, and this hypersensitivity causes accumulation of mucus and exudate in my airways. Also gonna cause bronchoconstriction. It causes my bronchi to contract. So when I contract, I'm accumulating exudate within my airways. What's gonna happen to the diameter now of those airways? I will reduce the diameter of the airways. And when I reduce the diameter, what's gonna be my problem here? So the air now is gonna be traveling from large cross-sectional area into a small cross-sectional area. And if I'm passing through a smaller cross-sectional area, what's gonna be the effect on here? I am faced with a lot of resistance. Very, very high resistance that I need to overcome. So if a person has asthma and he got an asthma attack, what he will experience? He's not able to breathe. He's not able to breathe. Why? He needs to exert more effort in order to pull the air against the high resistance applied by the constricted airways. But normally, why we are not facing a high resistance of the airways, it's not an issue for us normally, because simply the diameter of those airways that you're going to be passing through is very large. So you're going to be passing from a small diameter to a larger diameter, because simply you're going to have a lot of bronchi and a lot of bronchioles that you're going to be traveling through. So all of them, they have a much larger cross-sectional area compared to the one that you've started with, which is the trachea, for example. All right, is this clear? Is this clear? All right, great. So another factor that we are looking at in here is why having surface tension in the lungs will not create a problem for me. Having water lining my air sacs, creating a surface tension, this should be collapsing my lungs. Remember why this is not an issue for you? This is not an issue because simply you are releasing a detergent-like lipoprotein, and this detergent-like lipoprotein with what we've called the surfactant, exactly. And the surfactant is gonna have a hydrophilic portion and the hydrophobic portion. So it acts as a friend for both sides. It acts as a friend with the air. It acts as a friend with the water, preventing the water particles from adhering to one another, from creating a high surface tension, collapsing the lungs. So I don't have a major effect here normally, again, for the surface tension in the alveoli, because simply I am producing surfactant. And can you remind me, please, what is the type of alveolar cells or pneumocytes that is responsible for the production of surfactant? Type 2 alveolar cells, exactly. Type 2 alveolar cells. type 2 alveolar cells. Those are the pneumocytes responsible for the production of the surfactant that will be reducing the surface tension. So what if a baby was born prematurely, so he doesn't have fully functional type 2 pneumocytes, he's not going to be producing surfactant and he's going to have difficulty breathing. He's not able to breathe. He's trying to exert much more effort to pull the air in. Why do I need to exert much more effort to pull the air in? Because simply the lungs of this baby are trying to collapse because he doesn't have surfactant. Because this is my neonatal respiratory distress syndrome. Another factor that affects the ventilation in the lungs, this is going to be my lung compliance. What is compliance? What if I'm describing a person to be compliant? What this means for you? Compliant means it follows the rules. It's going to be doing what he is supposed to do. He is compliant. So what do you want the lungs to do? You want the lungs to expand whenever you have an increase in the transpulmonary pressure. And also you need your lungs to collapse, not fully collapse, but to reduce their size when you reduce the transpulmonary pressure. So transpulmonary pressure is a pressure that will be determining how big the lungs will be. So if I did increase this pressure, the effective pressure that keeps my lungs inflated, the lungs should be following and expanding. If I'm reducing the transpulmonary pressure, the lungs should follow and will reduce its size. Creating this variation in the volume of the lungs is what allows you to move the air in and out, if you remember. So what might alter the lungs compliance? For example, a person got recurrent infections in the lungs. So over time, he developed fibrosis. So now the lungs are stiff. They can't expand as they are supposed to, and they will collapse much faster than what they are supposed to. So am I following the rules in here as am I supposed to? With an increase in one transpulmonary in 1 millimeter mercury in the transpulmonary pressure, I should be expanding the size, but I'm not. And when I have a drop of 1 millimeter mercury in the transpulmonary pressure, I should be reducing the size of the lungs to this extent, but now I am reducing the size to this extent. So am I following the rules on here? No. So here we're saying that the lungs compliance has been diminished in case of lung fibrosis. I did replace the elastic tissue of the lung by non-elastic tissue. So it's not, the lung is not going to be responding as it is supposed to. Also, if I not producing surfactant, would I be able to expand the lung? So I will be increasing the transpulmonary pressure by 1 millimeter mercury. I'm expecting the lung to respond to this by expanding, but although I did increase the transpulmonary pressure by 1 millimeter mercury, the lungs are still going to be collapsing because of the effect of the alveolar surface tension. So in this case, am I following the rules? I'm not following the rules in this case. So also here, this is going to be a diminished compliance in case of reduced production of the surfactant. Also, if I have a problem in the chest itself, so a broken rib, for example, or obesity, or during pregnancy. So remember, what allowed the lungs to expand and recoil was not the air that you're pumping in the lung, but the change in pressure on the outside between the two layers of the pleura. Change in the pressure in here is what will allow the lung to either expand or to recoil. What if this person is pregnant? So would I be able to move the diaphragm down during inspiration as I am supposed to, all the way down like this? Or would I be faced by resistance? What do you think? I have a lot of resistance. I have a lot of resistance. So would I be able to change the volume of the chest as I am supposed to? I'm not able to change the volume of the chest as I'm supposed to. So what's gonna be the effect on here? If you can't reduce the volume of the chest, what's gonna happen? You are not gonna be able to drop the intrapleural pressure in here. And if you are not able to drop the intrapleural pressure, you are not going to be able to increase the transpulmonary pressure. And if you are not able to increase the transpulmonary pressure, your lungs will not expand. And if your lungs are not expanding, what's going to happen as a result? You are not creating a negative pressure within the lungs. And if you're not creating this negative pressure within the lungs, what's going to happen? Would you be able to allow the air to flow from outside to the inside? If this pressure didn't drop to -1, it remains a zero pressure. Will the air flow in? I have zero on both sides, so the air won't flow exactly. So if the air is not flowing, I'm not able to breathe. I'm not able to get the air that I want. So what's going to happen as a result? Difficulty breathing. So, and during pregnancy is one of the examples where I have limitation in the expansion of the chest, which will make it more difficult for me to breathe. Actually, this was a death way by which they used to perform a death penalty, which is called the peine de mort. So in a peine de mort, what they were doing to the person, they are killing him by adding weights on his chest. I'm not sure if you can see clearly the pictures on here. So they are adding weights on the person's chest, and as you are limiting the expansion of the chest, what's going to happen? This person won't be able to breathe. So I'm reducing the lungs compliance because the chest itself is not going to be able to move as it is supposed to. Can you see this picture on here? Yes. All right, this is a legal torture back in the days. This is how they are committing this legal torture by adding weights on the chest of the person. And again, when you add those weights, this will limit the thoracic flexibility. And if you're limiting the thoracic flexibility, this will result in a reduction in the lungs compliance, preventing this person from being able to get air in and out. All right, questions? All right, so we're looking here at a very important topic, which is really important for us for the upcoming lab exam, which is the pulmonary function tests. So pulmonary function tests are going to be conducted by using a machine. It's called the spirometer or spirometer. Spirometer is an instrument that measures the respiratory volumes. So you have a machine and you're going to ask the patient to breathe in and out through the machine, and the machine is going to be checking the volumes of air moving in and out. Why is it important to identify the lungs volumes in a person? This will give us an idea whether the person has an obstructive pulmonary disease, so he has a problem with the airways, or he has a restrictive lung disease affecting the lung tissue itself. So again, why do we need to know the volumes that will be moving in and out of the lungs? This will help us differentiate between two major sets of pulmonary diseases. Those are the obstructive and the restrictive lung disease. All right, so are you currently breathing? Are you breathing right now? When you're sitting, you're not exerting any effort to breathe. Do you breathe? Is there air moving in and out? Yes. So in this air, do you notice it? Do you notice that there is air moving in and out while you're sitting doing nothing? Do you notice this air? No, you don't notice this. This is what we call the tidal volume. This is the volume of air that's going to be moving in and out of your chest, of your lungs, without you noticing that you have air moving in and out. This is what we call the tidal volume. It's like a tide. Tide go in, out, in, out. Something slow. It's not a tornado, or it's not a hurricane. It's not a flood. Right, air move in, out, without you noticing. Here, this is what we call again the tidal volume. Moving up, this is inspiration. Moving down, this is expiration. So the amount of air that gets inhaled or exhaled with each breath under resting conditions, this is what we call the tidal volume. Can you get extra air in beyond this tidal volume? Other than the tidal volume, the air that moves in and out all the time during rest, can I get extra air from outside? All this air is an extra air that I can breathe in, right? All this extra air can breathe in beyond the resting tidal volume. So all this air that I can move in, that I can inhale beyond the tidal volume, is what we call here, this is my inspiratory reserve volume. So inspiratory reserve volume is going to be the amount of air that you can inhale by forceful inspiration. So you're going to be breathing out in maximally to move this extra amount of air beyond the tidal volume. This is my inspiratory reserve volume. Again, this doesn't include my tidal volume. This is the amount of air that you can breathe in more than the tidal volume. This is called again my inspiratory reserve volume. How about without having any maximal inspiration or expiration? Can I breathe out extra air more than the tidal volume? From resting breathing, can you move more air outside of your lungs? Yes, see on here, you can perform forceful expiration, forceful exhalation, and you're gonna move this amount of air that is normally kept in your lungs untouched. So you have extra air that you can move out of the lungs beyond the tidal volume. I have extra air that I can move out beyond the tidal volume, beyond the quiet exhalation. So what do we call this amount of air that I can move out beyond the tidal volume? This is my reserves that I can exhale. So we call this is my expiratory reserve volume. Expiratory reserve volume. This is the amount of air that I can breathe out beyond the tidal volume. So again, seen three lungs volumes so far. We've got the tidal volume, which is gonna be the amount of air that can be inhaled, exhaled with each breath during rest. Can you get extra air more than what you're taking through the tidal volume? The extra air that you can forcibly inhale beyond the normal tidal volume, this is going to be the inspiratory reserve volume. Can you get extra air out of your lungs? The amount of air that forcefully is exhaled beyond the normal tidal volume is going to be the expiratory reserve volume. All right, so again, I've got three volumes. The amount of air that's going to be moving in and out in a quiet breathing during rest, this is going to be my tidal volume. I've got extra air in beyond the tidal volume. This is my inspiratory reserve volume. And I can move extra air outside of my lungs beyond the tidal volumes. This is going to be my expiratory reserve volume. Did your lungs collapse when you are moving this amount of air out, the expiratory reserve volume out of your lungs? So if you maximally exhale, so I'm performing forceful expiration, did my lungs collapse? No. You're gonna still have some air trapped in your lungs. And this amount of air that is trapped in your lungs is what we call the residual volume. So I still have some air trapped in my lungs that will keep my lungs inflated even after maximal expiration. This is gonna be my residual volume. All right, so again, What am I looking at in here? I'm looking at the lungs volumes. So again, the amount of air that I'm breathing in and out during rest in a quiet breathing, this is my tidal volume. The amount of air that I can breathe in beyond the tidal volume by maximal inhalation is going to be my inspiratory reserve volume. The amount of air that you're breathing out by maximal exhalation beyond the tidal volume, it's called the expiratory reserve volume. And after you get this extra amount of air out of your lungs, you move the expiratory reserve volume, you're still gonna have air trapped inside because you won't allow the lungs to collapse. And again, why would the lungs fail to collapse normally? Because simply you've got all the time a negative pressure between the two layers of the pleural. So this negative pressure will always gonna be pulling the lungs out, keep them at least partially inflated. So all the time, it's always a negative pressure, always a negative pressure. And this negative pressure is what keeps the lungs at least partly inflated. So there will still be air in your lungs even after you perform a maximal expiration, releasing the expiratory reserve volume. And this amount of air trapped in the lungs that never leaves, this is called again my residual volume. Residual volume. Easy, easy. Any questions? Any questions so far? All right, great. So let's have a break for 10. When we come back, discuss more about the lungs volumes. We're going to be discussing the lungs capacities after we come back from the break. For the test, yes, this is really important for the upcoming lab exam, which is still on hold. Still on hold, waiting for the proctoring platform of the college to announce more details. So I've received an email yesterday stating that they did reach an agreement with some company, but it's not live yet, and we still have some meetings until we figure out what exactly we're gonna be doing. All right, so until then, the exam is still on hold, but this is something that's gonna be tested on the upcoming lab exam. Yes, definitely. All right, lungs, volumes, and capacities, and I will discuss with you how the questions here related to the topic gonna be addressed on the test. All right, after we come back from the break. For now, we can have a break for 10. We will discuss the lungs, volumes, and capacities after we come back. Right? We'll see you in 10.